Yeah.
Great. Thank you very much for joining this afternoon. Just giving it a couple of minutes there for people to join on, but it's great to see everyone on this slightly more springy afternoon. But I know there's a lot of busy people here, so we'll get started now. So thanks again to everyone who has joined. We'll keep on letting people in. But before we get started, please note that today's webinar will be recorded so that a video can be sent to all registrants afterwards. Please also keep an eye on the chat section during the webinar, where we will put messages and be answering any questions or queries that you have as we go along. But any questions that you do have as we do go through the presentations, pop them on the chat, and then we will address them during the question and answer session at the end. Now, you will notice that there is like a Q&A button at the top on Teams. Just ignore this. We're just going to do everything on the chat, if that's okay. So the main chat is where all the communications need to be, please. Finally, we'd just like to request that everyone checks that they do stay on mute, please, just to save any background noise causing distraction. But when we get to the question and answer session, if you do want to unmute and speak your questions out loud, that's absolutely fine. We'd love to hear from you. So today is a part of a two-part bonus series following our previous webinar course last year called Mastering Seating Assessments. And today's webinar will be all about posture in seating. So we're very pleased to welcome Joanne McConnell as our guest speaker today as well, who I'll introduce in a few minutes' time. So very much looking forward to hearing from Joanne as well. So here we have today's agenda. So just briefly going over that, we're going to make sure that we all understand what posture is and how it has an impact on health and well-being. We'll then learn about postural and pelvic abnormalities and how to address them with seating, and also how to monitor them over time. We will discuss how to consider posture in seating assessments so that you can offer support and comfort to every one of your individual clients that you're working with. And just really we'll learn how to use seating to correct and help with some of those postural issues. And then this will be brought to life at the end by Tristan Hulbert, who is one of our in-house seating specialists, and he will demonstrate what some of the functionalities look like on actual chairs from our range. And then again, at the end of the webinar today, we will have the live question and answer session. So again, just pop your questions on the chat as we go along. Brief introduction to who we are, Vivid Care, before I introduce Joanne. So some of you may have joined our webinars before, so welcome back if you have. For those of you who are joining for the first time, we have been supporting the healthcare sector for over 50 years now. We were previously known as Yorkshire Care Equipment, which some of you may recognise that name, but we're now called Vivid Care, which represents better the work that we do right across the whole of the UK now. So our mission at Vivid Care is to enhance lives through advancing care, which you can see there, and our focus is on providing specialist care seating, profiling in hospital beds, and then also mobility equipment. So we're really working every day to enhance quality of life for the people we work with, and then also to help healthcare professionals such as yourselves by providing better equipment, seating, and resources to support the work that you're doing. And we're actually part of Core Care Group. So our sister companies include Innova Care Concepts, who specialise in hoisting and installed healthcare projects. And then there is Aquadapt, who help with home adaptations. So without further ado, I'm very pleased to hand you over into the experienced hands of Joanne McConnell, who is an independent occupational therapist with a lot of experience. So welcome, Joanne. We're looking forward to hearing a little bit more about yourself and then your presentation. I will just stop sharing my screen and allow you to share yours.
Hi, can you see the presentation?
Yes.
There we go.
Yes,
so we're seeing your
excellent.
screen now.
Okay, lovely. I just need to, 1 second, do the layout option so you can also see me, which is sometimes a good thing, sometimes isn't. I've got a couple of pelvis with me, so I need to show myself. Can you see me now?
Yeah,
Yes.
perfect.
Yes,
Am I the
okay.
only attendee?
Pardon?
Am I the only attendee?
No, I don't think so.
That's all I've got listed here is me.
Oh, right. I'll make a start then. So, as has already been said, I'm Jo McConnell, occupational therapist, and thank you for inviting me today, Vivid Care, and thank you for all who've joined. So this is me, and this is my clinical background. I've been an OT for nearly 33 years. It's been a wonderful career for me, and I've worked in a wide range of settings. I've worked for social services in Birmingham Wheelchair Service, Regional Postural Mobility Service for and low limb prosthetics, Community Paediatrics in Worcester, Community Neuro Team, WizKids Mobility Therapists, Otterbock, ETAC, various roles, Clinical Manager, Education Manager, and Independent OT in various settings. Still do that. I was practicing clinically this morning. And I'm associate for Wheel of Health, where we look at complex cases through case managers for all postural and mobility needs and 24-hour postural care. And I also am 3 days a week the clinical lead for Worcester Wheelchair Service in the NHS. So quite a range. So I hope in all of those years, I've passionately practiced about being best practice regarding posture. So let's talk about why is good posture so important. So as OTs, and I understand there's a few physios amongst us, we all should understand why good posture is important. But here's just a few statements that should actually ring true to all of us. So good posture is one that allows maximum efficiency with minimum effort to perform a task. So how I'd like to explain this, just to ground us all together while we're sharing some learning experiences, is that if we provide seating that is such a great effort for the individual to sit in, the task then just becomes the seating rather than the activity that we want them to perform. So sitting in itself becomes the therapeutic task, which is fine if you're working on sitting balance, if you're working jointly with a physio colleague and the task is the sitting. But when we're wanting individuals throughout the day to perform a range of tasks, whether they're a child, whether an adult, they're looking at working in a chair, playing in a chair, feeding in a chair, just actively listening, being involved, then that needs to be energy efficient. It needs to take minimal effort to perform that. So ideal sitting posture isn't achievable for everybody, and that these are the individuals that we're working with and that we're asked to see are the individuals that need more expert eyes on them. And this is where we become the detectives, and we are assessing what do they need, what can they achieve, what can't they achieve. So not everyone can achieve the symmetrical upright sitting, pelvis in the correct alignment, knees at 90, ankles and feet supported on the floor or on a foot support. So not everybody can achieve that. This is where we come in with using our therapeutic and postural skills and understanding what we're trying to achieve and guide on. So the term good versus bad is often frowned upon. So let's call it unstable versus stable. So stability within seating is what we're always aiming for, that somebody feels safe, secure, stable to perform a task. So the stable side would be all of the words that we like to put into our reports, into our justification. So they're sitting aligned, their tone is typical, is normalized. They have maximum ability. They use least amount of energy for performing that task. We're minimizing damage to their body structures, to their body shape. Weight distribution is equal. So there's no peak pressures, we're allowing function, and we're facilitating independence. So if we look at the other column, the unstable or the bad posture, those are the things we're trying to avoid. But these are the hurdles that we're having to work with. These are the solutions that we're having to problem solve for and provide the best outcome within our seating solutions, our seating choices. So these are things that I'm sure all of us will have to deal with on a daily basis within our clinical caseloads. So it's just to understand good versus bad posture. I like to call it stable versus unstable posture. So I love this little picture. It's obviously one I've just grabbed off Google Images. And it makes me smile, but it also it says 1,000 things to me about why that little seat that cute little girl is sitting on is so wrong. We as OTs and physios and other healthcare professionals and the highly skilled product advisors that we're lucky to work with, we know that that's wrong. But then how often do we see an individual, we walk in to a home environment, we see somebody in a clinic environment, and we just eyes on and go, so much is wrong there. It's just using your postural analysis skills to understand what's wrong, why is it wrong, what can we fix, what can we change, and what can we facilitate. So there is no ideal posture. It does depend on that activity, on the condition, the clinical presentation, and the stage in life that person is at, whether it's a child like this little girl or whether it's somebody 90 in a nursing home. So good seating will allow for postural adjustments to take place. We don't want to provide seating that won't allow for changing needs, whether that's improvement or deterioration. We know that we need to adapt what we've provided many times, and we need to provide solutions that are cost effective, but also future-proofed. So we know that many individuals, including ourselves actually, tend to adopt poor postures throughout the day. But to our bodies, those poor postures aren't really that damaging because we can move about, we can adjust our posture. But when we're working with clients, service users who have poor postural control, poor postural stability, combined with some postural fixed deformities, they're the ones that we need to make sure they're in the correct posture so that when their body can't correct, that the equipment is providing that support and correction for them. So that's really important to stress. We can slouch about on our sofa, but we can choose when we change. We can sit on an office chair or a car seat that actually isn't the best for us, but we can adapt. When we're working with the clients that we work with who can't adapt, we have to be the detective. We have to be the ones that are providing that solution to protect their body shape. So landmarks of the pelvis, it's the biology part. We all know, hopefully, that the pelvis is the foundation for good seated posture. I might just add as well, as we all know, seating is just one of the many postures that we adopt as adults, as children. So seating, lying, standing for some individuals. So today we're talking about seated posture. So I have a couple of pelvises with me, but this one I like to hold because it's smaller. And just to really point out the landmarks here. So we're looking at the ASIS, and we can identify this on ourselves. So if we have a good rummage down now in a seated position and feel the ASIS, that's the landmark at the front of the pelvis on the anterior view that we need to be able to confidently, hands-on, say with permission, obviously with consent, I'm going to just feel your pelvis. I want to feel where the ASIS are. Anterior superior iliac spine, if anybody wants to know the long version, if you needed a reminder. And we need to identify that for many reasons, which I'll go into. If we look at the pelvis side on, like the second image, you'll see that the ASIS, if we're to draw a line, is higher than the PSIS. So turning the pelvis around now and looking at the third image, there's a lot on that diagram, but really what I need to point out to you is the PSIS are the bony prominences at the back. And this we need to be able to identify. On a child, it's easier to see because actually you can often see dimples there. There's not a lot of skin coverage in that area. It can be tender to touch, so be careful. So we need to know where the PSIS is, so posterior superior iliac spine, because we need to know what we're feeling and checking for if we're looking from a posterior view. Another point that's also important to be aware of are the ITs, the ischial tuberosities, because they are our sitting bones. And in a neutral upright pelvis, we'd be loading through the sitting bones. When a pelvis is posteriorly tilted, we'll be loading through the coccyx and the sacrum. So just important little biology reminders that we all know, but sometimes we forget the terminology and get a bit scared of, oh, what do they mean when they say that? We're all at different points in our career, I'm sure, and different levels of experience. So looking here in the lateral skeletal view, let's remind ourselves what that looks like. So the first picture is the neutral pelvic tilt. So we're loading on the ITs and we're sitting in a nice upright posture. Our knees are at 90, our ankles are at 90. And then the middle picture is posterior pelvic tilt, as we said here, rolling backwards. This is often referred to as sacral sitting. That's because we're loading on our sacrum. When we load on our coccyx and sacrum, which many people do, you see it a lot in the elderly, and you see it a lot also in children. It's because the pelvis isn't being held securely. When we load in that way, it becomes a very non-functional posture compared to a neutral upright pelvis. And then if we look at the third image, that's when we have slight anterior tilt. This is a useful position for some people. It can be a more active position for active propulsion in a wheelchair. If somebody's sitting dynamically at an office desk, it's good to have a slight anterior pelvic tilt. And it also then enables us to bring our trunk upwards and to open up our thoracic spine. But it's also common with some conditions. So the neuromuscular conditions, muscular dystrophy, spinal muscular atrophy, and then also spina bifida, we often see the anterior pelvic tilt is one that's adopted and sometimes the only position that they can sit in. So a reminder of posterior pelvic tilt. If we look at the second image, you will see that that's a visualization of what a little bit exaggerated, but not. We do see people like this, where they're sitting with posterior pelvic tilt, and then the upper spine is going into kyphosis. So we have increased pressure loading on the coccyx. The spine tends to flex forward into kyphosis. Difficult to maintain the knees at 90, and we can get hamstring shortening. So these are all things just from the pelvis being tilted posteriorly. This is the impact that can have. So really in our first toolbox, we need to make sure we're choosing seating that can hold the pelvis securely, that we've got a well to accommodate and hold the pelvis and block the ITs. All of the posterior pelvic tilt can have a much bigger picture posturally than we realize when we just think, oh, that's fine, their pelvis is posteriorly tilted, that's okay. It is okay, but we need to know how that impacts on the rest of the posture presentation on the spine, on the head. So let's look now assessment of pelvic orientation. What I want to do in this really is to, whatever your experience level, is just a refresher and just to demystify how important the pelvis is, but also to demystify the terminology. So pelvic rotation is purely when one side of the pelvis is forward of the other. And that's what we're showing on the first image. So with that, it can appear that there's a leg length discrepancy, but usually it is just that one side of the pelvis is forward of the other. So again, by putting our thumbs on, like in the third picture there, that's a ex-colleague of mine, and we're actually palpating the pelvis. You can see one thumb's higher than the other. So what we're looking at there is that we've got pelvic obliquity. So pelvic obliquity, one side of the pelvis is higher than the other, and you'd identify that again by thumbs on, hands on with the ASIS. You can see in the image again there that you'll have the spine following, so you'll start to see in the lumbar spine that the spine is curving to in its accommodation of the pelvic obliquity. You'll also see that there's peak pressure, there's increased loading through the one side of on the lower side of the IT. So these are all, do we understand? Is the pelvic rotation, is the pelvic obliquity? Looking at the positions of the hips, I like to use some visuals here from textbook, but also it's good to see real life visuals and how that presents in the human body. So turned inwards in the first picture, we're talking about internal rotation. You can also see from the image that there's some pelvic obliquity as well, and that the legs are forced together. This can be really tight when there's increased tone, and that we say that the legs are adducted. An easy way to remember this, if you're struggling with lots of terminology, if you're newer into your career, adducted, we're adding the legs together. So we've got internal rotation and adduction happening there. So these clients, and then it affects the foot positioning, as you can see, and these clients will need accessories to help realign the positions of the hips and the legs. Centrally, we have the neutral hips, which is what we're always aiming for, but we know many of our clients can't achieve that position. And then the third picture is where we're looking at quite an exaggerated, turned out, externally rotated. The legs are widely spread, and this is abducted. So again, we would look at trying to, what can we do to change this? If we leave the person sitting in that position, it could be that they're fixed in that position, which we always really need to check. But if we can correct that, we'd want to be adding in some leg positioners to realign the legs so that they're narrower. We're going to have to go to a much wider chair than needed with this presentation if we don't realign the femurs, because we want the femurs to be in more neutral alignment, like the middle picture, than sitting widely abducted. So there's many accessories that we can use for that in whatever seating we're looking at. If it's suitable seating, it should accommodate that. Okay, sorry, I'm going quite quickly. There's quite a bit to fit in here. So just to compare between pelvic rotation and wind sweeping, because they are two presentations that's often confused with clinicians. And I see this a lot within wheelchair services, but also in my roles privately with adults, children, and in training presentations. So pelvic rotation, as I said, is when the pelvis rotates. But if we only look at somebody from the front, if we never check from up above, looking down above, we won't always know the difference between pelvic rotation and wind sweeping. So this is where it's important to check posteriorly what's going on from behind. So in pelvic rotation, we would see that the PSIS, so as I said, the back here, the PSIS would not be level, it would be rotated forwards. Whereas in wind sweeping, if we're to check from the front, from above, and from... Sorry, I can hear somebody else. Sorry, I thought it was a question. So with wind sweeping, what's happening? The legs sweep to one side while the trunk and the pelvis remain forward. So we'll often see this when there's a dislocation or a subluxation of the hip. They'll often be complaining of hip pain, chronic hip pain, and there's usually a strong tone or muscle imbalance. But it's important to understand the difference between pelvic rotation and wind sweeping. And sometimes if we haven't done a thorough assessment, we wouldn't see that. So I would say if you're querying pelvic rotation versus wind sweeping, the best way to assess for this is on a plinth always, and to look in supine lying, then you can see the difference. So There's not always a time within assessments, but I think it's really important when we're putting our name to pieces of equipment and our recommendations that we understand what are we reporting, what are we seeing. So we've talked about the spine, we've talked about the pelvis, and now we're going on to the spine. So spinal deformities and seating provision. So again, lots of terminology that's thrown about in reports. Let's be strong and clear on what that terminology means and how it presents clinically for that individual. So does the client have a kyphosis, a lordosis, a scoliosis? Do they have all three? So how can this affect the overall posture and function of the individual, and how does this follow in the natural curves of the spine? So all of these issues will change the spine's shape. It can be that these shapes are not yet fixed, that they're flexible. Again, the only way we'd really know that, we don't have X-ray vision, we're not in an X-ray room. We have to put our hands on and confidently feel the client. So always ask for permission, consent. But I would say for complex seating, we should be assessing everybody on a plinth wherever possible, in sitting and in lying. If you're not confident at that, try and work jointly with another colleague, try and work with a physio colleague who's often very confident and comfortable with these mat evaluations. So we're looking to provide the correct seating that can accommodate different body shapes and that can be adjusted for changing needs. This is crucial. And if the seating doesn't do that, and we know that there's a degenerative condition, neuromuscular condition, we then know that we've not provided seating that is going to suit that individual. It's not future-proofed. So in your justifications clinically for seating provision, we need to be really strong at stating why we need something different, because we need to make sure it's future-proof for changing clinical presentations. So looking closer at scoliosis, again, if we're struggling to remember all sorts of terminology, if we're earlier in our careers, or maybe if we're a student, the easiest way to remember scoliosis is the S, because the spine can go into the S shape when we have a double curve. We don't always see a double curve, but in a more developed scoliosis, we will see the curve in the lower section, the lumbar section, and then in the upper section. It can affect people of any age. Many children have scoliosis, and then it can, if left unsupported, it can develop very, very quickly. I'm sure we've all worked with individuals whose scoliosis is rapidly developed in a matter of months. Surgical intervention won't be considered for children until they've stopped growing more. So there's so much that we need to be aware of with scoliosis, and that we have a responsibility for providing the correct seating to support. There's not time today to go into all what we can do to support scoliosis. It's more about just understanding the difference of postural spinal presentations. So first of all, is it correctable or fixed? Again, when we don't have X-ray machinery. So hands-on with a client, we should know whether that, if we're confident in handling, we should know on a plinth whether that is correctable or fixed. We could go into the S shape of the spine if it's a double bend, a double curve, and we know that these individuals be the ones that aren't really that able to correct their own posture, so we need to give them the correction they need. And we know that throughout the day, further asymmetry will occur if we're not going to add the functions of tilt. Very common with neurological conditions. So going on to lumbar lordosis, common presentation, again, with neuromuscular conditions such as muscular dystrophies, spinal muscular atrophies, again, spina bifida. And with that, we'll see the anterior pelvic tilt. How do we support that lordosis, and how will tilt function impact that? So we must check the lordosis in lying to understand whether it's fixed or correctable. So if somebody goes into supine lying and you can still get an arm or a hand under them, there's still the gap. It hasn't softened out. It hasn't flattened out in lying. We know that that is fixed. So by adding tilt, we can make them more comfortable. We need to provide some support behind the lordosis, gentle, soft support, but not too aggressively, because we don't want to push them into further lordosis. So we need to have tilt that's variable, that's easy to change, and that they can tweak their position. And I would say sometimes with the lordosis to use a combination of tilt and a little recline to open up the hip angle. We can work with the angles in a positive way, and especially if it's not fixed, we can actually provide a great deal more comfort for the individual. Kyphosis, this is unusual. It's a different picture than I was expecting. Kyphosis, we had changed this picture, sorry about that. We need to look at allowing space for the kyphotic spine. So we know that the thoracic and cervical spine will be flexed forwards, and we need to allow space for that. So we don't want to give them a solid back. We need to make sure that there's space for the spine to immerse fully. So tension adjustable straps are really important for kyphosis, and comfortable, soft support surfaces for them to immerse deeply into. Really common with motor neuron disease, which I'm sure many of us have worked with these clients, and supporting the head is very, very difficult for motor neuron clients and other clients with kyphosis. So yes, this is an earlier version of the presentation. I'm afraid there should be an image there, but we're going to see some examples of this when we go on to the product presentation. So tilt in space and the use of tilt in space is really crucial when we're looking at more complex seating. So it uses gravity in a positive way throughout the day when an individual may be stronger in the morning, but in the afternoon, they can't cope with sitting upright. If we think of MS, for example, we can have really good, strong mornings, and then the afternoon, they couldn't tolerate being sat in an upright position. It's less tiring, and we can vary the tilt throughout the day depending on the activity. We can help by using tilt, we can help reduce the risk of fixed spinal deformities occurring when we use it effectively. So just being able to vary and tweak the angle throughout the day will really help with that. Excuse me. Too much talking. We can help improve head positioning by tilting the client back. They can often maintain good eye contact with tilt in space, whereas in an upright posture, they will start to lose their head control with fatigue, whereas with tilt, with appropriate head supports, we can enable them to interact better, we can enable them to communicate and just be part of everyday life, whether that's a child in school or whether it's an adult. There's a lot of evidence supporting the reduction of risks of pressure ulcers on seated surfaces when using tilt. And best practice, we should be using tilt regularly throughout the day. So I always say in my role in wheelchair services, within an hour, you should look to be tilting for a minimum of 10 minutes, 10 to 15 minutes, and a good range of tilt, not just a slight bit. We need a good range of tilt to give our bodies a break, to realign, to take the pressure off the ITs, to take the pressure off the vulnerable seated surfaces. We use tilt in a positive way and redistribute the load evenly onto the back, allow our shoulders to come back, allow our head to come upright. I just want to say a little bit, sorry, I've jumped off there, about recline also before I finish, and to say that the reason I haven't done a slide or talked too much detail about recline, that's because actually when using recline, we need to be quite careful. So I'm sure we've all worked with clients where recline has been overused, and then if only recline is used, think of reclining the car back in your car. you can actually push the person forwards. So you're trying with all of your other interventions to hold their pelvis in a good position. If you only use back recline, you're allowing their pelvis to push forwards. And that's when often you'll get the call, oh, they're sliding out the seat. Right, what are you using? Recline. You need to use tilt. And then if you need a little bit of recline, so tilt, we're keeping all of our angles in the same position. We can elevate the legs, obviously, but tilt and then a little bit of recline can be very beneficial, but just recline on its own is never really advisable. So we need to make sure that we've got the correct seating functions in place when choosing our seating to enable the best outcomes. That's really all I needed to say, but just to really say that I hope that whenever you're working with posture and seating, that you really do take the time, when we have the time, make the time even, just to know that we've done our best for that person with the information we have. We've done our postural checklist. We know what position their pelvis is in. We know what position their spine is in and what we need to do as clinicians to support their body shape. So when we sign on a report or on a prescription for equipment, we're signing that we're happy with that. So we need to be sure as clinicians that we are happy with that. And we're not just using something because it's in our store. If the thing that's in our store isn't right, we then need to try something else. I cannot stress that enough, whether I'm working in the NHS or privately. I would not be happy to put my name to something if I wasn't 100% happy with the outcome clinically for that individual, and that posturally I've done my best job as a clinician for them. So sorry, that was a soapbox moment there. Okay, I will hand back to the capable hands of Vivid Care and I'll stop sharing my screen. So sorry, that was a bit of a whistle-stop tour and I hope you've got something from it. Thank you. Thanks
very, very much, Joanne. That was really, really helpful. And again, it's a great refresher.
Thank you.
And just for varying different levels of experience, it's good to revisit these things as well. So just regarding the presentation there, obviously the last one without the last couple of slides with the other images, we will circulate the slides on with all of the images and the diagrams and everything, so everybody can view those afterwards.
Yeah, sorry, don't know what happened there.
No problem at all.
Yeah.
So that's fine. So yes, thank you again. That was brilliant. And I will now hand over to Tristan Hulbert, who is one of our seating specialists, who will talk a bit more about some of the things just for a few more minutes using some of our chairs. Over to you, Tristan.
Thank you. Can everyone hear me all right?
I can hear you, yes.
Excellent. Right, so just at Vivid Care headquarters here, and just going to go through a couple of the chairs, and more importantly, just a few of the accessories and features on the chairs, just to show you what might be needed to try and help with some of these postural abnormalities, some of these pelvic conditions or spinal conditions, and what you might want to think about when specifying a chair. So we've got a couple of chairs, just a couple of chairs in the to show you today, and these are both care chairs. So we've obviously got the rise and recline chairs for people that are still standing. Care chairs tend to be for those that are hoisted, but remember that accessories can, and some of the features can be the same on rise recline chairs. So we had a slide earlier from Joe as to tilting space and the importance of tilting space. So you'd tend to expect to see tilting space on a care chair. As you can see, you've got a large range of tilting space. And what you're really doing is you're spreading the user's weight all the way along and keeping in a good pelvic position and spreading pressure and ensuring that you're getting right back into the seat there. This is a manual tilting space, but you can get electric versions as well. And as Joe was saying earlier, it's very good to keep adjusting that level of tilt throughout the day and keep adjusting that position so that you're taking pressure off those different areas. Now, also obviously got backrest recline as well. And just to remember again that we need to be a bit careful with backrest recline, because it can put you into a poor seating position, but there are a lot of situations where you do need an element of backrest recline as well, or you just need to open the backrest recline up more. So the tilting space and the backrest recline, this is the Lento care chair, and this is the Lento Trio care chair. Now, they're exactly the same, so they've got the same actions on, the same features, but it's just the backrest that's different. So I'll go through the backrest in a second. But before we do that, just want to talk about seat sizing. Now, seat sizing is really key for posture. If you've got a seat depth that's too long, you can end up with the sacral sitting we spoke about. If it's too short, you're putting a lot of pressure on your thighs. There's a lot of study into the seat sizing. So all our chairs are very much adjustable without tools, and you can actually get someone from 5'2" in this particular chair, right up to, we've had someone of 6'9" in there. So there's a lot of adjustment without tools in the seat sizing. So seat depth, seat width as well, that's important to get that right. Otherwise, if it's too wide, you can start leaning to one side to try and get support. So it's important that you get your seat width right as well, and then obviously your foot plate height as well. Now, as we heard, the pelvis is the foundation of seating, so we need to make sure the pelvis is in the right position. And if you are looking at someone who's got pelvic abnormalities, as we've gone through, we might want to first look at what they're actually sat on, so the seat cushions. So our chairs come as standard with a visco foam or a gel cushion, but the good thing is that there's a solid seat base there, and you can swap cushions out. And what we often do when we've got a lot of different kind of pelvic needs or posture needs, we might look at something like this. So this particular one is an STX cushion. We do other ones as well, like the Specs range too. But really what you've got is a modular cushion that's very adjustable. You can take the cover off. There's loads of different parts in there. You can add wedges to help realign the pelvis. You can have a pommel like this one's got, and leg channels to try and keep those legs in a good position. So this type of seat is really helpful for your more complex needs. Moving on to once you've got your pelvis correct, you can then look at the backrest style. So as standard, we tend to have this waterfall lateral backrest, and what we've got here is three soft cushions, but you'll notice the middle one here has got some soft lateral support to the side here. So just to try and get a good midline position, but this is kind of entry level. It's nice and soft, it's comfortable, and just helps try and keep that spine in a upright position. Now you can swap the cushions around, and the beauty of this type of cushion as well is that it comes off, and behind each one of these you've got a zip, so you can add wadding, you can take wadding out, and you can really adjust that to suit that individual's spine. So we heard earlier about lordosis, for instance. So in that case, you might want to pad out the bottom cushion just to give a little extra support, but making sure we're not adding too much to pronounce that further. So that's the standard type of backrest, waterfall lateral backrest. The next kind of stage from there is something like this, which I love this product. This can just be swapped out. So same care chair, just take the three cushions off and put this in its place. This is what we call a cocoon backrest. And what you've got is basically that soft lateral support all the way from the head down to the hip area. And with this, you can also use wedges behind to really kind of cocoon and mould to the user's body shape. There's also zips on the back, like with the other cushions, so you can adjust the amount of wadding in each area. So that's a really nice soft option that gives a lot of postural support, but there's a lot of flexibility in that as well. From there, you can obviously get things like your metal lateral support. So come around from the back and the adjust in and out. That's more of a kind of firmer support. But then the next kind of stage from there is moving on to this model of chair. So as I said, the same chair, the same base unit, but this is called the Lento Trio. And the reason it's called the Trio is because we've got the 3 wing sections here, and each one of these are adjustable in 4 places. So we've got a lot of adjustment in these arms, and you can set them to really align someone's posture and give them a lot of support. And we've got height adjustment on the chair too, so you can move that backrest up and down, and you've got angle adjustment. You've also got adjustment on the head section, so to give good head support. So this section tilts forward and back, and there's it's really for someone who's got quite complex needs, and you can really tailor the level of support all the way down the backrest. Then after that, you'd be looking at other accessories, such as we've got a chest harness fitted to this chair, so to keep a good upright position there. There's also 2-point belts, 4-point belts to prevent sliding forwards, and a lot of different types of accessories. I've just covered a few off there. And lastly, just to come down to the leg section, we spoke about sometimes you need quite a lot of leg support. So as standard, we've got a slight shaping. I don't know whether you can see that here on the standard leg rest. We've got a kind of channeled leg rest that just helps keep those legs in line. Obviously, we've got the cushion that we can put in place with the pommel and leg channels if you need something more. But then you've also got this option here, which are larger leg laterals, a lot of support in there, just to keep those legs aligned. Then lastly, on the bottom section here, we've obviously got the adjustment in height for the foot plate, but we've also got angle adjustment on the foot plate as well, which sometimes might be needed if you've got conditions such as drop foot, that kind of thing. So I hope that goes through some of the features that might be useful for some of these conditions we spoke about. If you do need any further sessions in terms of like a practical demonstration, very happy to come out and let you try the different chairs and go through the options, let you sit in them. But also we do offer an assessment service where we can come out if you've got a particular client that you're struggling to see. We love a challenge. Please do get in touch. Hope that helps. Back over to you, Braden. Thank you.
Brilliant. Thanks very much, Tristan. Yep, that covered off both of those really well. So again, when we send around an email after this with the recording and the slides, we'll pop in links to these chairs as well, and a few other resources which you can have a look at on our website in case they're helpful. So this is technically now the question and answer session. Now, we haven't had a huge amount on the chat, but I've got one from Chloe. Thank you, Chloe. Is there a postural assessment tool you would recommend to make sure we are covering everything during our assessments? And thank you, Joanne, for answering there, saying that most trusts will have their own assessment form that you always note. But I just wanted to highlight that we actually have one. If you haven't been offered anything by your trust, then we've developed an assessment tool which goes through all of the different elements as like a checklist. You can go through each point, and now that's something you can do either on your phone or a laptop or a tablet, or otherwise you can print it off and fill it in by hand. So again, we can include a link to that tool if that's of any help for you, Chloe. I'm not sure if anybody else has got any questions at this stage, though. Feel free to pop them on the chat now or unmute.
Yeah, what I would say to Chloe as well, which is such a good question, Chloe, that I think when you have that pressured time to assess somebody, I think you quite rightly, you think, have I remembered everything? You know, I don't know what scenario you're in, but in some services, it's like you've got a 45-minute slot or an hour slot to do that assessment, gather all your information. And there's a lot to take in, especially if you're not as experienced in seating and complex posture. So that checklist sounds fantastic, Braden. And just using it, getting it out and just thinking, tick, tick, have I looked at this? Have I considered that? Because otherwise you can get away. You start looking, what do I want to assess this client in? What are my go-to things that I want to trial? And then you think, oh, did actually I get that? Did I get this? What I would always say to everybody is get as many measurements as you can at that point, even if they're not the most accurate measurements because of the position the person's in and there isn't a plinth to lie them on. Get as many good measurements as possible, because then to give that to the equipment provider, to the equipment specialist, for them to be able to come out and do the best assessment for you. And having done those sort of roles myself for 2 companies, the amount of times I'd have so little information, you'd get there and you'd think, if only they'd told me that, if only I knew this, I could have done a much better clinical assessment for them, which would have saved the clinician's time, would have saved the family's time, and just would have led for a much more positive outcome. So gather as many, it might seem irrelevant to you, but gather as many little things. All those little snippets are invaluable, aren't they, to the equipment provider, that you've got as much information when you go out and do that assessment. That's definitely one thing I would say.
Yeah. No, that's brilliant. And the other thing I would say in terms of, helpful little things to help during assessment, have a look through some of our previous webinars as well, because we've had a lot of lots of OTs. They come up with their own little sayings and things to help them remember these things, which might be of some use. So please do feel free to go and have a look through some of those. No, that's brilliant. Well, we still haven't had any more questions on the chat, but we are heading towards an hour mark now. So I will move on because I know everyone is busy. But again, if you do think of any more questions afterwards, or you want to find more resources or anything like that, please do reach out to us. We love to have a chat and to help you out in any way we can. It's why we're here. So we'd be really chuffed to hear from you. So I will just move on to our last few slides, just literally a couple more, and then we will wrap up for the day. So that moves us just what we've been talking about already, really, to point out that we have a free resources section on our website. It's literally just vivid.care/our resources, and it includes all sorts of things that you can use, including the assessment checklist, ebooks as well, such as a guide to seating assessments for healthcare professionals, and we've got an exciting new one coming next week actually, which is about seating bariatric or plus size patients. But as well, the resources section includes a blog with a huge wealth of different articles, educational articles, justification forms and templates as well, in case you're trying to get funding approval, and also just a whole range of different training videos and recordings of the previous webinars. So it really does have it all. Have a look on there, have a browse, and yeah, if you have any questions, then please do get in touch. So as mentioned at the beginning, this episode this webinar today is an episode of our 2-part bonus series. So this one is all you need to know about posture. Now we are going to be coming again in a few weeks' time about for our next part which is going to be all you need to know about pressure care in seating. So Joanne, you're going to be joining us again for that one, and
What's up with me again?
Yeah, no, thank you. So we'll be launching that in the next week or so, once all that's confirmed, and you can register your place for that in case you're interested as well. We'd be glad to see you all again, and please circulate with any friends or colleagues as well who might find it interesting. So again, thank you very, very much for your time this afternoon. If you do have any questions, these are our contact details. Or if you'd like to book an assessment, please do reach out. But thank you, and thank you, Joanne, for your time this afternoon as well.
Thanks for asking me.
All right, no problem. Thank you. Enjoy the rest of your day all.